Hello, and thank you all for joining this session from Salford Royal Foundation Trust, which is an NHS Global Digital Exemplar site and is spearheading digital healthcare transformation in Greater Manchester. I'm delighted to introduce Dr. Jim Ritchie, who's Chief Clinical Information Officer at the Trust, who's here to tell you more about the Digital Control Centre, for which he is Programme Lead. Jim, over to you.
Thanks very much, Catherine, and thanks for the invitation to be here. I'm Jim Ritchie. Hello, I'm a kidney doctor by background and the CCIO for Salford Royal. I'm here today to talk about our Digital Control Centre programme, often called the DCC. And as much as I love the programme, I hate the name, and I think this is more about how we are using technology to deliver coordinated care than anything else. So, to start, I just want to address where we saw the need for this. I'm from Salford, and our probably most famous export historically is Lowry, a fantastic painter. And on the left here, we've got a picture he did of the Ancoats infirmary many years ago. And really what that shows is outpatient management, and we all accept that hasn't changed enough. But I would also suggest in that our approach to hospital management is again another legacy system, whether it's technical or process legacy. It has not kept pace in its evolution in the same way that healthcare and digital transformation of our clinical interactions has changed so much over recent times. And what this means is that we have a system that has, by nature, constrained capacity, increasing demand, and no better way of balancing these two things, which certainly for us creates almost an internal market or competition for the same resources. And we are faced with difficult decisions where we have to balance cancer work against other elective surgery, our local population needs against regional challenges due to some of the specialist services we host. And we believe that by addressing this, we can help not only improve patient outcomes, but patient experience, the quality of care, and really importantly with that, our staff working lives. So when we initiated this programme, we had a number of hypotheses, and probably fundamental to what I'd like to share is the idea that developing a digital operating model for healthcare is something that drives operational and financial benefits, as well as providing a platform for future change and all the good stuff that we know is not too far down the road, such as precision medicine, genomics, and giving us a view for the future of how we incorporate that into our day-to-day processes. It's a really busy slide here, but I think it makes an important point. Healthcare is not simple, okay? If it was, we'd all cracked it long ago. We like to refer to healthcare delivery, especially in acute sites, as a complex adaptive system. Now, I guess what this means at a clinician or a patient level is that there is a slight disconnect between how care is delivered and experienced and how care can be managed within the overall organisations that we work in. As a patient, care is a linear process. Things happen in a sequence, and whether that sequence is linear or cyclical is hard to determine. When we as expert staff, operational leads, improvement teams look at improvements that we could deliver in care, we tend to focus on these journeys and we map them in the opposite way. We work backwards from the end point and try to understand where any problems may have arisen. And of course, this creates a false picture because care is not linear. Care is a fundamental output of the systems that we are putting our patients through. And when we think of a system, we can absolutely see healthcare delivery because a system is a collection of independent parts, each of which can affect the behaviour or the outcomes or the priorities of the other. And the fact that this is a complex system really reflects the fact that for the same input, because of these complex interactions, we can often see different outputs. And what that means for us as improvement leads is that the system needs to be considered as the sum of its interactions, not the sum of its parts. And to deliver an effective control centre that can advance our agenda, we need to improve our interactions rather than driving point improvements for part of the process. On this really sort of rough and ready diagram, we've sketched out a genuine journey of a patient who was with us in our organisation for over 100 days. In that time, she had 15 ward moves, 1.5 units of blood transfused, more than 300 biochemical investigations. And at the end of this, she spoke so highly of the care that we delivered, whereas what we can recognise is we missed opportunities to deliver that better. If we decompose her journey and think how we could have improved our operational awareness or our ability to care for her, we can start to define solutions at various points. But we can see, and the dots show this, that these solutions actually offer value across the totality of the patient journey. So optimising one component is not going to allow us to improve care. We have to optimise the system to drive effective change. And where we want to get to at Salford and the Northern Care Alliance is to really understand the truth of these interactions. The cartoon on the left shows what many people would describe as a process map. But this is an idealised view of the world. A follows B. The reality is, of course, more complex. And on the right, that's again just a schema to indicate the fact that people will move through processes in a variable manner. They will loop back at various points. And unless we can understand this, we will not be able to drive step change improvement. And that is where our control centre vision will take us. So, again, talking conceptually about what we will deliver through this programme, we've got 4 layers of activity. At the top, we can see an analytics layer. We have a huge wealth of data in this organisation and across Greater Manchester. And what we need to use this for is the creation of a common operational view, both within acute sites and across the entirety of the health system, from primary to quaternary care. This data needs to then be fed down into a planning layer across the middle, where we can not only effectively forecast our demand, whether that's arrivals, departures, length of stay, but we also need to be able to decompose this into the components of care. In hospitals, we very commonly talk about estimated date of discharge. Somebody should be with us for 4, 5, 6 days. But unless we can describe the activities that allow us to achieve that, measure against these and identify any dynamic constraints that are occurring in our complex system, we are less able to deliver that. And that's absolutely key to our vision. This then feeds down, of course, into a care delivery layer. And we have to understand how these data-driven insights are enacted in a day-to-day process. And through a combination of process change, behaviour change, we are working to deliver, in essence, short interval control with a daily series of board rounds and ward rounds, manage our progress against the care plan, as well as delivering that care to our patients. Finally, wrapping around all of this, but hidden away here in the bottom corner, is a management system, making sure we embed and spread the correct behaviours to allow our staff to actually own this rather than have it imposed on them. And through some very detailed work, considering the benefits, we believe strongly that this could allow us to deliver a 20% improvement in our operating capacity, significant financial benefits by reducing average length of stay, and especially the super long length of stay patients. We can improve quality and safety by understanding the components of care and where we're struggling to deliver those. And importantly, for me as someone who works here, we can improve the staff experience by enabling proactive decision making, reducing manual processes, and improving communication throughout the organisation. This sounds tech heavy. And for us, I think a key part of this programme is that this is about people, process, and then technology. It's 70% change in behaviour. There's a lot to consider on this cartoon, but the key message is that the digital control centre is a foundation upon which we build behaviours and improvement. This is an enabling tool, and we have to develop it as such, otherwise it will simply be something else that we ask our staff to use. We want this to enable ward-level problem solving. Frontline staff know what the issues are and they know how to solve them. And what we want to do is give them the tool to do that, but also to understand that in alignment with our organisational goals, drivers and objectives. So getting to where we are now has required a deep understanding to be developed of our organisation. We've gone to great lengths to map the problems related to our processes. We've understood our patient journey from the very beginning to the very end of the pathway. We've decomposed each individual area in our organisation into its constituent parts and understood the processes and the variation in those. This is probably the most detailed mapping of an organisation that's occurred across the NHS. And out of this has come a thematic analysis which shows us where our pain points are, where our problems are. And off this, we have built operational blueprints that will describe the patient journey in line with the staff journey, aligned with the support processes, the systems and the data flows, and how this creates visibility to enable a thriving and better run organisation. Out of that, of course, we've understood our benefit opportunities, and we've developed a catalogue of 42 benefit areas. But ultimately, this will be tech enablement that is designed and built to support the behaviours that help us solve these problems. And as Catherine's alluded to, the NHS needs to replicate and scale. And our vision for the control centre product that we are building is, in essence, a modular vision. We have a series of component parts shown on the left, from a target operating model down to individual digital modules, either of information display, process automation, or information sharing. Delivering the management system at the top is just foremost in our mind, because this is the thing that will allow us to build routines to deliver proactive impact from our control centre products. The operational blueprints that sit beneath that enable us to build an operational system which aligns to our vision for delivery, coordinated care, by describing and allowing us to get into the detail of each layer and aspect of the patient journey. And this will allow us to have a modular, configurable approach that we can extend within our organisation, across our hospital group, and hopefully spread and scale across the NHS. And to close, appreciating I think I'm probably running up towards time, we of course want to do this in line with who we already are. We're an organisation that is built upon the principles of continuous improvement, but we want to, in essence, give our staff the tool that will enable both quality improvement and quality control. Throughout the work, we're building a configurable set of process metrics aligned to the tools that the staff will be using to enable the organisation to set high-level goals or drivers, such as reducing on-the-day theatre cancellations. These can then be decomposed into leading indicators that we'd want to measure, but then owned and defined at a local ward level to say, how can we contribute to this? What are our targets to improvement that will help align with this? This enables the wards to understand where we would hope to drive improvement. It allows them to understand their role in improving the organisation's position, and we can then roll up multiple, potentially disconnected pieces of improvement work under the same leading or North Star goal. So I think I've probably got to time, so I'll stop there and just say a large thank you for your time and attention today. This is a partnership between the Northern Care Alliance, of which Salford is the lead organisation, and Hitachi from a corporate perspective. If I've not run out of time, I'm happy to take any questions in the chat. Thanks very much. Watch challenges did you have in baselining performance ahead of comparisons with the new data-driven care plans? Loads, Simon. Absolutely loads. Part of the challenge is, I believe, we've got some really great clinical data and we've got some great operational data, but separating these can be challenging. We did an extensive period, about 4 months of time and effort to understand not only what our performance goals would be, but how we would effectively measure these and how we would remove any confounding metrics. We have had to come to an acceptance that the digital control center platform is probably going to be something that helps us measure these things better. We are really good at describing our clinical outcomes and much less good at describing some of our operational challenges. So we've gone as far as we can, but it's been a hugely interesting exercise in understanding our limitations there. And slightly awkwardly, I can now see Helen's comment. You can only ever see the first slide, which is slightly embarrassing. I was on screen share and I didn't see that, so my apologies. If I've not run out of time, I've not had Catherine stop me. I was just about to answer Helen's question about achieving buy-in from staff. Been a real journey to do that. We've had to extensively engage in the design phase with each staff group, and one of the, I think, key things that we've done is identify, I think it's about 34 personas across the organisation. Personas and I may have dropped off here. It says I may be unable to connect, but I'll keep going. 30 odd personas to understand what people do, what they see as their job, and what they see as not being their job. And we've mapped these challenges back to our process to again understand where the people challenge aligns with the system challenges. And hopefully we have identified as our leading sort of target areas that address both staff challenges and operational challenges.